thyroid eye disease. Patients can be euthyroid, hyper or hypo. That's a question that, they'll give you a scenario where the thyroid panel is normal. It doesn't matter, okay? Women are 6 times more likely to have Graves than men. Ages are middle age, 40 to 44, 60 to 64. And but 90% are hyperthyroid at some point. Smoking is the only thing that's found to actually worsen the disease process, okay? The most common ophthalmic feature is eyelid retraction. So that's really important. Optic neuropathy, although it's a huge complication of Graves, it's not that common. Okay, so eyelid retraction, know that. That's the most common presentation. So there's an autoantigen to the TSHR and IGF-1R. The lymphocytes attack the body's own tissues. And patients can present with diplopia. They can have tearing from exposure, eye irritation and redness. We'll go over where conjunctival redness is important to look for, whether it's due to the inflammation or due to exposure. And a lot of patients have this staring look. Okay, so this picture is nice because it shows that there's tendinous sparing here, but the rest of the muscle is thickened. All right, and so there's 2 phases, or at least we think there's 2 phases, active inflammation and passive congestion. There's some debate as to how long the active phase is. I think a safe board question would be 1 year. So some people say 6 to 18 months. Some people say a firm 12 months. Some people go up to 24 months. But I think 12 months is generally accepted, okay? And that's Rundell's curve, where you have this active phase of inflammation and then you sort of get a burnout phase. So oral steroids are right now probably the most commonly used medical management, but radiation isn't really typically undertaken anymore. Orbital decompression surgery followed by eyelid muscle surgery and then eyelid retraction. And that's an important board question. So they'll always ask, what's the order of treatment for Graves' disease? So you'll want to say decompression, then the muscles, and then the lids. All right, so here again we can see tendinous sparing here at the insertion. And I think this scan is pointing to the ophthalmic artery. So here the muscles are very thickened, optic nerve, and then the artery. So again, staged surgical management, orbital decompression first. There's different walls to approach for orbital decompression. There's the medial wall, there's the floor, and there's the lateral wall, the greater wing. So again, think about why you would decompress in order to open up a potential space, right? So you can open up a potential space down here in the orbital floor to the maxillary sinus, and you can open up a potential space in the ethmoid sinus. And so the tissues literally just prolapse into those potential spaces, and that's where you get the decompression. Superior orbital fissure and inferior orbital fissure provide landmarks for lateral decompression. Taking out the zygoma in the lateral wall, you can shave down a lot of this bone approaching the supraorbital fissure, okay? So the basin and the trigone would be areas where decompression would be useful. Extraocular muscle surgery is next, because after you do a decompression, there's changes in length tension curve of the muscle, and that can cause a difference in their measurements pre-op and post-op after decompression. So a lot of surgeons like to undertake balanced decompressions, and some don't. And for that reason, you always deal with the muscles next. And finally, eyelid repositioning last. So this patient has eyelid retraction, and his upper lids were brought down. So quick facts, eyelid retraction, again, most common feature. Graves' disease is the most common cause of unilateral and bilateral proptosis, more common in men, more common in hyperthyroid. Smoking makes it worse, and steroids for optic neuropathy, although you can decompress for optic neuropathy. Okay. Idiopathic orbital inflammation is next on the list. Patients have proptosis and painful eye movements. These patients can benefit very, very much with steroids. These patients have thickening of the tendon, so the tendonous insertion is not spared. And here's a patient with acute onset left eyelid inflammation, and you can see the haziness around the lacrimal gland. And she improved with steroids. Okay, lymphangioma. Age of presentation, typically first and second decade of life. There is a slight female predilection. It's a benign vascular malformation and typically located in the head and neck. The histopathology, diffuse unencapsulated mass that interdigitates with normal tissues. So there's irregular vascular channels with venous and lymphatic components. So there's a thin-walled, attenuated endothelial layer, interrupted basement membrane, absence of pericytes, no smooth muscles. Loose fibrostroma with scattered follicles and collection of lymphocytes, plasma cells. So how does this relate to treatment? So it's a malformation rather than neoplasia. So really, radiation wouldn't benefit these patients too much because it's a malformation, right, rather than neoplasia. Observation is probably the most important thing here. It's important to try to stay away from operating these patients. You can control this blood cysts if needed, but otherwise it's important to try to avoid surgery. And there are sclerosing therapy as an option too. Lymphangioma, we can see here that it's pushing the left globe inferolaterally here. And on CT MRI, you can see the fluid-filled cyst there. Sarcoid can affect the lacrimal glands. It can really affect any part of the eye in the orbit, but lacrimal glands, we'll talk about that. 80% are identified on gallium scan, chest x-ray for hyalurodenopathy, and when you do want to do a biopsy, look for the granuloma. Don't just biopsy any part of the conjunctiva. So that's a good board question. Hamartomas and chorostomas, know the difference between them. Chorostomas are cells that are not normally present. Cystic lesions, classify those. So dermoid cyst is the most common childhood orbital tumor. It can be congenital. It's a progressive enlargement. So patients that present later in life, those are typically deeper ones. And patients that are diagnosed in childhood, those are more superficial. What happens is that it occurs at the suture lines, and that's where the embryonic tissue gets stuck. And so these patients typically can benefit from excision at some point in their life. Smooth and painless dumbbell lesions, again, management surgery, avoid the rupture. It causes a lot of inflammation. Tell your patients not to squeeze on them and not to try and pop them. And when you want to take them out, identify and remove them from the suture line. Nasolacrimal cysts. So capillary hemangiomas, tumors composed of anastomosing small vessels of the capillary caliber. Patients can also present with an atotic eyelid or a proptose globe. I think you spoke last night about beta blockers as a treatment option for kids that are at risk for amblyopia. It's an important board question, or some sort of treatment at least. It's a gray zone between hamartomatous or malformation and true neoplasm, and it's the most common infantile benign neoplasm, so you will see this in practice. Half are present at birth, and the remainder appear shortly thereafter. So in the first 6 to 12 months of life, they increase in size significantly. They tend to involute after about a year. 75% involute after the first year, okay? So over the next 4 years. So they increase in size for 1 year, okay? Then they start to involute. After the second year of life, 75% will go away over the next 4 years. Okay, so superficial or strawberry colored and deeper bluish colored. Differential diagnosis, as you can see here, okay? So, yeah, the complications, again, 1, amblyopia, 2, skin problems, strabismus, proptosis, asymmetry, ptosis, keratitis, and optic atrophy, okay? So again, amblyopia, just have that in your head, and that should be a quick indicator for treatment if that's what you're worried about. Patients also have visceral hemangioma, so you may need to refer them to their pediatrician on your board exam. I mean, they're difficult to diagnose typically. Okay, so the Facey syndrome, posterior fossa malformations, hemangiomas of the cervicofacial region, arterial anomalies, cardiac anomalies, eye anomalies, and sternal or abdominal clefting or ectopia cordis. It affects girls 9 times more than boys, and infants are at risk for a CVA, okay? So treatment, we'll just go over that one more time. There are reports, for obviously beta blockers, but the dermatology literature advocates systemic steroids as a mainstay treatment. Okay, and that can cause skin discoloration, and that's something that patients should be aware of. Yeah, and then at the bottom you see beta blockade preliminary but profound improvement. Okay, so location, supranasal orbit, medial eyelid. enlarge again over 6 months to 1 year, 75 involute by age 5. Multiple visceral capillary hemangiomas associated with thrombocytopenia. That's called Kasabach-Merritt, and that's also in the BCSC. All right, so here's a picture. We can see the right upper eyelid and regression after steroids. Cavernous hemangioma is the most common benign tumor in adults, middle-aged females, slow progressive proptosis, faster during pregnancy, and you see an encapsulated, well-defined, homogeneous lesion on CT. These can be excised. Okay, so we see here, you can see here in the right orbit, we see a well-encapsulated mass. And all right. So carotid cavernous fistulas are important to also recognize. Here we see arterialization of episcleral and conj vessels and chemosis of the conjunctiva in the bottom left. The bottom right, you see the patient is proptotic. And then in the CT, you see that the extraocular muscles are also thickened. And that's something that can commonly happen with a patient with carotid cavernous fistula. Okay. So let's see the difference between these two pictures, because that's important. In the top figure, we see that the erythema is only over where the extraocular muscles insert. And in the bottom, you see the arterialization of blood vessels that occurs with the dural shunt. And that goes all the way to the limbus, okay? So the top one would be due to inflammation. The bottom one would be due to a fistula or a dural shunt. Okay, and here, not all CC fistulas, but many have a dilated superior ophthalmic vein. Okay, so that would be a direct versus an indirect, probably wouldn't. Okay, so lesions of neurogenic origin, optic nerve glioma, meningioma, plexiform neurofibroma, and schwannoma. Lesions of embryonal origin, or teratoma. Here's a patient with an optic nerve glioma on the left side. You can see that he's got a thickened nerve here. So typically 25 to 50% are associated with NF. There's a gradual axial proptosis. The chiasm is involved in 50%, and it's a slow expansion and growth. Treatment options can be observation, but surgery and radiation and chemo. Okay. Surgery, obviously, when it's not involving the chiasm. When it is involving the chiasm, you go for radiation and chemo. Neurofibroma, proliferating Schwann cells. So you'll see plexiform neurofibromas and in NF1. So look at the left upper lid here, and you just see infiltration of a plexiform neurofibroma. So typically, I think there's that bag of worms sort of feeling you get when you touch that, when you examine a patient. These patients also have sphenoid wing dysplasia. Okay, there may be absence of the sphenoid wing. So that's another important thing to know with orbital neurofibromatosis. NF1, autosomal dominant, cafe au lait spots, axillary freckling, fibroma molluscum. Those are the skin nodules. Again, sphenoid wing dysplasia, pigmented iris nodules, glaucoma, and optic nerve glioma. So there's, I think, there's all these criteria. There's all these things you have to know about the criteria. So just commit these to memory. I'm not going to go over all of them with you here, but this is something that you guys can study at home. I think it's important to know these because